from the Department of Psychiatry at UT Tyler Health Science Center and the CPAN and PeriPAN program. So glad that you're joining us today for today's session, Managing Anger and Aggression in Children and Adolescents. Our speaker today is Dr. Kylie Schneider. And as she's getting her PowerPoint up, I'm going to stop sharing. And I would like to tell you just a little bit about Dr. Schneider. So Dr. Kylie Schneider is a clinical psychologist here at the University of Texas at Tyler Health Science Center. She received her bachelor's degree in psychology and child development from Texas Christian University and went on to earn her master's and her PsyD in clinical psychology at Baylor University before completing her health service internship and child and adolescent fellowship with University of Texas at Tyler Health Science Center. Are you all able to hear me okay? Okay. Dr. Schneider has worked with children and adolescents and their caregivers in community clinics, residential treatment centers, inpatient hospitals, and academic medical centers. Her clinical focus is on providing trauma-informed care, improving parent-child relationships, and teaching behavioral management for neurodevelopmental and disruptive behavior disorders. Her research focus includes early intervention, preventative care, treatment adherence, and clinical efficacy research. Currently, she serves as the Associate Training Director for the Psychology Internship Program at the hospital and acts as the primary investigator on the Youth Depression and Suicide Research Network study at University of Texas at Tyler Health Science Center. And that research study is also part of the consortium that we belong to here at UT Tyler Health Science Center. Part of what we're trying to do to positively impact the mental health of children and adolescents here in Texas. So I'm going to hand this over to Dr. Schneider, allow her to go ahead and share her screen, and we can get started.
Thank you so much. I am trying to get the computer to cooperate. Okay. Okay. Laura, is that showing up correctly?
Yes, ma'am.
Wonderful. Okay. Well, hello. Thank you very much for that introduction, Laura. I appreciate it. I'm excited to get to chat with y'all today about anger and aggression in adolescents and how we can, children and adolescents, and how we can help manage that within our care settings. I'd like at the top to give a special shout out to Elizabeth Hooker. She has previously contributed a bunch to creating this PowerPoint and providing this education. And so I very appreciate her input and help. Okay, so our objectives for today are really to just define and kind of compare some of the clinical terminology that we run into related to anger and aggression with kiddos. We'll have a better understanding of the etiology of anger and aggression as it pertains to different diagnostic classifications, behavioral health classifications that you may run across. We'll look at some methods for intervention specific to care settings and age groups, and then we'll be able to apply some of that knowledge with a vignette. Okay, so we're just going to start by kind of understanding anger and aggression. So a little bit flip-flopped here, but so anger as a term is actually referential to the feelings or the emotions that a person has, right? So someone can feel angry. They don't necessarily act out anger. So anger or angry is really just the emotional label for that intense, what is usually labeled as a negative emotion for individuals. Aggression, on the other hand, is that behavioral manifestation of anger oftentimes. And it can kind of get broken down into a couple different spaces that I think a lot of us are used to. So passive aggression is something we've heard before, right? Someone being passive aggressive, but it's not always a vindictive methodology of expressing our anger. A lot of times it can just come from that idea of how somebody copes, you know, that how their fight or flight is having them express this anger, or how their anger has been previously received will determine what that expression or aggression can look like. So passive aggression can really be that sulking, procrastinating, acting like everything is fine and not really talking about it, that kind of behaviors. Open aggression is what we usually think of as being the quote unquote problem, right? So this is going to be our kiddos who externalize it, who are either physically or verbally aggressive, either to themselves or to other people. It can also be called open aggression. Because again, it's that thing that we're putting out into the world. It's the one that's a lot more obvious, and usually the thing that brings people in more. People don't like passive aggression, but it's not usually the thing that's going to bring our kids into our office all of the time. And so sometimes it's the silent friend that we need to listen out for. An assertive anger or assertive aggression can be an adaptive expression, right? So when I'm working with families and kiddos, I really try to emphasize that no emotion is inherently bad, right? Anger in and of itself has a function. Every behavior also has a function. There is a reason it's happening because it's trying to get a need met. Now, whether or not it is getting that need met in a helpful or unhelpful way is kind of what brings us to needing assistance and kind of what's up for debate. So assertive aggression can be effective expression of anger. And that would be like being very confident in your expression, talking about it, being assertive in having a conversation about why you're upset. Kind of those, what we would think of as like pretty adaptive conflict resolution skills. Tantrums are going to look more like that impulsive, immediate expression of distress, right? Again, a little bit different than maybe how we would talk about aggression, because aggression is kind of that overarching expression of anger. A tantrum is one manifestation, and it's usually pretty emotion driven. So it's going to be that one big burst, usually not thought out or planned, and really kind of comes across in that tantrumy way. So this is the I get something I don't want, or I don't get something I want, and I scream and I cry and I kick and I throw myself on the ground. Oppositional or defiant behavior, however, is more of a pattern of behavior that usually goes along with like a pretty irritable mood, and some other pretty significant behaviors that, again, are looking more like this isn't just me having an outburst because I'm emotionally dysregulated. This is me having a responsive pattern that I have developed that is usually not functional. So this is not listening to adults, fighting with adults a lot, refusing to do things, refusing to regulate, kind of that group. And then disruptive behavior is, again, kind of that next level of very chronic expressions of anger that get in their way, usually in the classroom setting. So what can cause anger? Usually we can kind of look at this as two buckets. This one is really talking about diagnostically what can cause anger, and then there's also just some situational environmental things. So diagnostically, anger isn't just coming from a mad place. Sometimes it can come out because of anxiety. So irritability and aggression can be part of that fight or flight, like we were talking about. And research shows that these rage incidents can actually occur in over half of children who are presenting with anxiety. So you got to think, if I'm really anxious about something, that's setting off that fight or flight, that alarm system in my body, which is literally telling me I either need to run away from a danger or fight a danger. So it makes sense that anger can be a secondary emotion to anxiety. And sometimes what can be helpful when we're thinking about our kids or asking our kids is, what is anger the mask for? Because anger is a easier feeling to feel because it's external. We get to be mad at somebody, it's something. It doesn't have to sit inside of us. So usually that's kind of how it can be connected to a lot of these things. Anger can also come along with depression or mood disorders. Diagnostically, irritability is a criteria for younger kiddos when we're diagnosing things like depression. And I don't know if y'all are familiar with a newer classification called disruptive mood dysregulation disorder that also incorporates this piece. So irritability is usually a more common manifestation of depression for our younger kiddos. Adjustment disorders have a classification of irritable mood or mixed mood inside of it. So an adjustment disorder is someone who is presenting with maybe anxious or depressed symptoms, isn't meeting full criteria for depression or anxiety diagnoses, and they have had a significant stressor or change in environment that has brought on that symptomology within the past 3 months. So you can have this irritable mood manifestation of that when we're kind of adjusting to an acute stressor or change. Boys are more likely to present with that irritability. We know that mood altered states can also increase aggression, and we know that our kids and our teens can sometimes explore different substances. So knowing that substance use can be a part of that. Burgeoning or prodromal psychosis can also come along with some aggression. And so looking at history can be important in that way of what's the family history here and what has that looked like in others. And then some environmental stressors. So again, kind of similar to that adjustment disorder of if there's enough going on in the environment, if the quote unquote right things are happening, it can sometimes set our kiddos off. And we'll talk more about a couple environmental stressors on the next slide. Obviously, anger can come along with our disruptive or defiant behavior disorders. Anger, irritable mood, aggression are all part of that clinical picture, right? We see increased aggression with about 3 to 5% of that ODD or conduct disorder really kind of coming out in that way. And males are twice as likely to present with disruptive or defiant behavior disorders than girls. So it's something that we'll definitely see more. It doesn't mean that our female patients are not also presenting with these symptoms. It's just more readily diagnosed in our males, often because, again, they tend to be more externalizing. Trauma is another really big missed bucket for anger. And it's kind of similar to that anxiety presentation or that depression presentation. It's that response to fight or flight. It's a response to trauma reminders, which can be internal or external, right? So a trauma reminder can be literally seeing a stimulus related to my trauma. It can also be I'm having a memory or a flashback, and that sets me off. And so anger isn't always associated with trauma. It's more just seen as being a bad kid, so to speak. And I think that's true of all of these. Anger is never really seen as a symptom of disorder. It's just seen as a bad behavior. And so understanding this connection can be important, especially true for our friends with neurodevelopmental disorders. So that includes attention deficit hyperactivity disorder, intellectual disability disorder, or the autism spectrum disorders. Anger can come along with those diagnoses purely sometimes, yes, out of a functional space. I know that anger and being expressive enough with my anger helps me avoid things or gets me closer to people that I want to be close to. But it can also be due to, again, symptomology of the disorder, things like impulsivity or overstimulation. One big thing that I like to help families understand kind of across the board with kiddos, but I think especially our friends with neurodevelopmental disorders, is the difference between a can't and a won't behavior. A can't behavior is it is literally something that is developmentally beyond what I can do, versus a won't behavior is just something I'm refusing. And again, anger and aggression can come with either one of those, but I think the can't behaviors are the ones we really want to watch out for. Especially for our kids who are aware of their limits and are just having a hard time acknowledging them. I can get pretty angry that I know I'm falling short in this way and I really want to be able to do it, so I externalize. Okay, I'm going to skip ahead to this one really quick. These are some of those environmental things that can also come along. So yes, it can just be environmental conflict, right? Conflict between my peers, conflict within my family system, stressors in my community, but there can also be some like physical stressors and environmental things. So helping kids check in with their pain, understanding that if they're in pain or discomfort, irritability and anger is a really common expression of that. Illness is also one. If I'm not feeling good and I don't feel like I'm at 100% to be able to deal with the stressors in my life, then I'm going to be more quick to the irritability. Medication changes are always really important to monitor for that side effect and just how it is changing yes, the expression of anger, but also their own ability to regulate distress. Like we said, substances can be part of that, the social environment being part of that. Um, Sometimes the hardest conversations we can have with our families is about how things are being modeled. Um, because if a caregiver or an important adult in their life, sometimes an older sibling or an older peer, is modeling certain methods of distress tolerance and emotional expression, kiddos are sponges and they're gonna do it and they're gonna copy it. Whether we want them to or not. So the social environment can be really important. And media use can also definitely impact. Yes, again, in that modeling way, but also I think we're seeing more and more data about how technology and media use is changing the way our kids are able to process, the way they're able to manage their own distress, because they're, again, that kind of like threshold for how much I can handle is getting a little bit shorter. And we know that social media use and media in general can be a stressor. I think especially so for our preteens and that group in today, when a lot of bullying and comparison is happening online. Diet and nutrition, also very important. Hangry is a term that we've introduced to my 3-year-old, and he's doing a great job of acknowledging when that's happening for him. And I think that is an interesting comparison to keep in mind of anger is not always pathology. I think the way that we can respond sometimes, rightfully so, can be anger is a big issue that we need to like take care of right away. And kind of like I was saying on the other slide, anger is an expression of need. And all emotions are an expression of need. We just have to figure out what it's asking for. Unfortunately, a lot of times our kids learn to meet those needs in unhelpful ways. So even just when you see a kid getting really angry, go through the checklist. Are you hurting? Do you not feel good? Are you hungry? Did you sleep well? Caregiver and provider mentality can be, did we change the medication? Have we had a big life shift? Those kinds of things being important. These are just some buzzwords that we had noticed come up in charts and in descriptions of kids in the school environment, in the care environment. Do y'all see any words on here that you've had caregivers describe their kids by, or that you've seen in charts and notes about kids? What are kind of the common ones that y'all see? And if you want to put them in the chat. Moody, bad, violent, yes, would go alongside that, not being a word we'd love to hear. Uncontrollable. And I think our question becomes controlling. Yeah. Irritable. And I think that, thank y'all. And if anyone again wants to put in the chat, I think the question kind of becomes, why can some of these words, especially maybe some of the ones that really give us like the ooh, like a violent or bad, uncontrollable, why can they be problematic? Having tantrums, yeah. Oftentimes they can be a problem because they can be very labeling, right? And like we were just talking about, there's a big difference, right? Yes, thank you, Laura. There's a big difference between I'm angry because I'm irritable because I didn't sleep well. I'm angry because I just had to switch schools and no one wants to talk to me. And I'm aggressive because it is part of a bigger pathology that I'm experiencing. All of those things are very different and get handled very differently. And so sometimes when we have these words like violent, that can get very stigmatizing. Parents can also be really overwhelmed. But we also balance it as providers with, I also have to document effectively in my note. I have to describe what's going on, and I'm going to use the words that somebody gives me. Yes, doesn't recognize behaviors as functions, exactly, and attributes it more to flaw. That's 100% correct. So I think it's just that mindfulness of how we are documenting. And if we are going to use a word like violent, let's back it up. Because there's a big difference between violent with the intent to harm and violent as in I'm dysregulated and I maybe knocked stuff over unintentionally because I was trying to escape a situation while I was angry or maybe having a tantrum. Okay, thank y'all for that. Let's see. Okay, so we're going to read a quick case example. And I would like y'all to keep this in mind as we kind of move into our next section about what are some common interventions for anger and aggression that I think can be readily applied within a care setting. So Jack is a 10-year-old male who just started 5th grade. He presents to his doctor's office with his mother to establish care as they just moved to the area from out of state about 2 months ago. So Jack's mother states he's always been an energetic kid. However, teachers have been complaining that Jack lashes out in class when he's asked to transition between tasks. He lashes out when he's asked to work independently or stay in his seat. He's also been pretty aggressive with his peers during recess. So, just real quick, I'm being mindful of time. Any immediate thoughts on where some of Jack's anger or aggression may be coming from? Anxiety, autism, ADHD, intellectual adjustment, stress from the move, totally. Yep, transitions. Awesome. Y'all are all thinking in the exact same way, right? I love that nobody came out and just said bad kid, bad egg, rotten apple. There's definitely that mentality of there's a couple different things. Could be diagnostic, could be environmental, could be peer related. Yeah, possible education deficiency. Yep, could be a learning difficulty. Could be that recent move. Absolutely. Y'all are thinking exactly in the right zone. Okay. So now we'll get to talk about what interventions can look like. So kind of at the top, these are just some factors we want to consider, right? When we are trying to understand the function of a behavior, we kind of want to understand what I like to refer to as the history. So we can kind of break down what happens like before, during, after, right? But we also want to understand what is the context? What is the history of this behavior? So it can be pre-existing diagnoses. It can be the child's maturity. Just because a kid is 7 doesn't mean they are emotionally 7. Or just because a kid's 15 doesn't mean they're emotionally 15. And that's for our typically developing kids as much as it is for our neurodevelopmental kids. Is there any trauma? I think in our East Texas area, that always has to be a question. I obviously do clinical work here at the Health Science Center, and I also work with our interns who see a lot of patients. And I can probably count on my hand how many times we have had a case that had 0 trauma involved. Almost everybody, whether it is part of the presenting concern or not, has a trauma history. So asking that question can be really important. Birth order can play into it, right? How much ownership do they feel they have over their behavior? How much modeling have they had? Kind of where they are in the pecking order, so to speak. And then again, that social environment. What is being modeled? What is being encouraged? Again, I think that is true in an East Texas environment of being mindful of what are the social expectations for different age, gender, race demographics for kids, and how is that being embedded into kind of their own development of coping. And then just paying attention to those developmental ranges, specifically when it comes to coping and regulation, right? Because that at the end of the day is going to be the best intervention for our kids. We help them recognize when they're feeling angry. We help them understand what that anger is trying to achieve. And then we have to tailor our interventions to their developmental level. And our interventions are going to be regulation based. So in early childhood, that 3 to 5, they are in this stage of other regulation, right? Very rarely is a 3 to 5-year-old going to be able to sit in a corner and calm down on their own. We have to intentionally help them calm down to the point of getting their body in a calm space, helping them take deep breaths, supplying the skills for them, right? The independent regulation is not happening here. Middle childhood, they're moving more to this co-regulation, right? So we kind of start to encourage the child to recognize their own needs, their own dysregulation. We don't have to label so much for them. We can kind of prompt them to reflect on those things and then help them do the coping that works for them, right? They kind of know what works at this point. We want them to generate the ideas on their own, and then we help support them in doing that. As they move into that adolescence phase, most of the time they're going to be able to engage more in that self-regulation, right? As long as we give them the place and the space, they can do it on their own. Again, that is by and far not the rule, though. And so it's this dance between respecting their autonomy, so again, helping caregivers understand that we kind of got to let kid cope in the way that works for them, not necessarily in the way that we want them to, and engaging kid in picking out what works for them and being able to do it, but also setting limits around like, okay, but what is the line where we say you do need help still, and being able to establish that. So one of the first things I always introduce to families is, again, how do we understand the function of behavior, right? The ABCs of it. You can see on this chart, this is actually one that I use with families. There's a little bit of that history, right? The who, where, when, what has been going on, what is kind of the context for it. But then we walk them through the ABCs. What was the activating event? So what was your child doing right before the behavior happened, right? Really being descriptive about what was going on in the immediate situation and maybe sometimes in the historical, right? So that he didn't sleep so great, or, he and this teacher really butt heads. This is just the teacher. He's good with everybody else. This is just the one, right? And then we describe the B, the behavior. And we don't just want he was bad or she threw a fit. We need descriptions of that, right? We need to understand what types of activating events lead to specific types of behaviors, because all events are not created equal. And there may be some people where I whine and other people where I physically lash out. And then the consequence. So the consequence isn't the punishment. The consequence is what happened immediately after as a result of the behavior. And this is where you can get into the idea of the function, right? So if the activating event is Jack was requested to put away his language arts book and get out his math book, and he fell on the floor and he threw his book and he started screaming, and then the teacher kind of picks him up and ushers him out into the hall, right? The consequence is that someone gave him immediate attention and then pushed him out into the hall, right? A function, though, could be connection, because I got that one-on-one time with the teacher, and I got to escape what I didn't want to do, which was pull out my math notebook, right? So consequence isn't inherently the punishment. It's just what's happening after. And what happens after can kind of help us understand better of what that emotion or what that behavior is trying to achieve. Once we get there, we can start to think about what skills work best, right? So de-escalation is always a good tool at the top, especially if a behavior is becoming extreme. A big thing that we want to do is always respect kiddos' personal space, right? When they're dysregulated, and we'll talk about emotional awareness in the next slide, if they're beyond, if we have a scale of 1 to 10 on how dysregulated or how upset I am, how out of control my emotion is making me feel, once they get beyond an 8, nothing good is happening. We're past the point of no return. Their frontal lobe has turned off. They're not thinking anymore. They're reacting. And we need to help them get back to a space where they can respond. So respecting their personal space and trying not to escalate any further is kind of the goal. When we're talking about not escalating any further or provoking anymore, that means we're not going to try and push the topic. We're not going to try and explain why their anger is inappropriate or their behavior is wrong. We're not going to try and help them understand the lesson there. We are purely trying to get them to come down from that 8, 9, 10 into a more functional space. We can use our language to ground them in a little bit, kind of verbally get them to respond to you. Be really short. Again, if my frontal lobe is turned off, my processing is turned off. So the shorter the explanations, the fewer words, and even taking it down a developmental notch, right? So even if I do have a 15-year-old that I know I can explain things really well, I might simplify my language even a little bit further, just so it's something that they can hear. Identifying, again, the function, right? I understand that you're angry because I'm having to, you can't go hang out with your friends this weekend. I get that that's upsetting. I would be frustrated too. Trying to be empathic about it and label it, and maybe introduce some of those other words, right? So you're angry because you're hurt about their action. Kind of help them understand that feeling behind the anger mask. And really listening to them, right? It's very easy because anger, again, is this aggressive emotion. It's this externalizing emotion. We kind of jump to assume sometimes because our own caregiver fight or flight is turned on in this moment, that it is meant to be vindictive or malicious or hurtful. And if we can really, again, help families and ourselves as the providers understand that anger is just trying to meet a need, then we can better hear what our kids are saying. Agree or agree to disagree. Always maintaining those good boundaries around it, right? So again, my kiddo's 3, but in our house, we say you can be mad, but you can't be mean, which means you can be upset. You can stomp your foot if you need to. You can cry. You can do those things, but you can't use mean words and you can't use mean actions. That's never okay. So establishing some clear limits and boundaries can help kids understand what the expectations are, obviously, but also sometimes can help facilitate that co-regulation and them learning how to regulate on their own, because it gives them bounds to do it in. If it's a free-for-all for regulation, which sometimes it can be, right? Sometimes we're just like, you need to calm down, you need to figure it out, then they don't really know what to do, and they're going to do with what feels good in that reaction instead of responding. And then, yes, coach them in how to stay in control. So what are some tools that can help with this de-escalation that we're teaching families, right? Emotional awareness is always the go-to. And I'll say some of these other slides are things that I personally feel, yes, are attached to different therapies, which we'll talk about, but also can be those quick 5 to 10 minute skills that you can teach families in a provider's office, or in a quick consultation. So emotional awareness is a big one. And the best thing I can say, regardless of age, is make it a visual tool. So having them identify their own scale, right? So I often start talking to families about a 1 to 10 type of scale. But kids can get creative with it. I've had kids who have shown me their emotion dysregulation, if anyone's familiar with Dragon Ball Z, like the different levels of Super Saiyan. I've had people, I have a kiddo who's done it based on different types of bugs, for their anger. And so having this understanding of whatever kind of tool they want to use to help understand how their anger goes from 0 to 100, we facilitate them in doing. But the idea is we want them to understand that it is a scale. It doesn't jump 0 to 100. It jumps 0, 1, 2, 3, 4, 5, all the way up, right? And once we develop that identification tool, then we can start to have them understand what are the cues. So what is the difference between your anger at a 5 versus your anger at a 10? Because if we recognize that difference, we can start to catch it earlier. As we talked about, we really want to encourage caregivers that whatever kid is deciding on, they also need to practice and implement, because the best way our kids learn is through modeling. So helping encourage caregivers kind of get that buy-in of like, I know you're not the one who needs to regulate, but we need to model this. And oftentimes our caregivers are the ones who also need to regulate. These systems are bidirectional, right? So having them model the use of the emotion identification tool, right? So if they've decided on a scale like this that's color coded with those smiley faces, have parents also use it or caregivers use it. You know, they can tell kid, hey, I'm at a yellow. I know that because I can tell that I'm having a lot of, tension in my body and my face is getting hot. Helping them do that. And that's that practicing that emotional labeling, right? I'm helping them understand that. Some therapies, just for if you ever want to give specific recommendations to families, or you even want to do a little bit of research on your own, that involve education on emotional awareness, are going to be your things like cognitive behavioral therapy, dialectical behavioral therapy. I'll say this, when you Google DBT, it's going to talk about borderline, and that can scare a lot of people. DBT skills are applicable to everybody. They don't have to be connected to a borderline presentation. Parent management techniques or parent management training is really a kid and caregiver collaborative intervention that teaches parents how to deal with tantrums, and kind of teaches these co-regulation skills alongside it, emotional awareness being one. Trauma-focused CBT does the same thing as PMT and CBT. It's just with trauma at the core. So if we know that trauma is what's causing the anger and aggression, TFCBT can be great for that. And then sometimes it's a social skills training. Our neurodevelopmental kiddos, our ADHD kiddos, and autism kiddos, helping them understand those skills around, again, that assertive aggression or that helpful expression can be part of it too. So once we understand our emotions, we can identify them and we can hopefully identify the escalation. Then we want to teach them relaxation and regulation. There are 100 ways to cook this egg, but some of the ones that can usually be nice little nuggets to give. The keywords you'll look for are things like grounding, regulation, mindfulness are good. These are just some. So grounding techniques really look at taking kiddos out of their heads and into the present moment, right? We can almost think about, again, that escalation of emotion, that deregulation, kind of like a tornado. It starts to spin up, right? And once I'm spinning at that 8, 9, 10, I'm, lost to the wind. So grounding techniques kind of help bring us out of our heads where those emotions and those thoughts are spinning, and back into the environment to kind of help us get some separation from that. This is where you may have heard of things like progressive muscle relaxation, where we teach kids to squeeze the muscle on the inhale of our breath and release the muscle on the exhale. And that's actually helping send a lot of good feel-good chemicals into their body. It can reduce some of that physical tension and helps turn off that fight or flight response. Engaging with your senses is also a really great grounding, because again, if I'm focused on how my shoes feel on my feet, I can't really think about what I was angry about. And so helping kids engage with their senses, helping them understand what makes them feel calm and what feels comforting, and engage in that self-soothing. Observing is very similar. Again, a favorite skill of mine is called 5, 4, 3, 2, 1. And so it's where you have them engage with their senses and find those different numbers of things, right? So it'd be 5 things I can see, 4 things I can touch, 3 things I can hear, 2 things I can smell, 1 thing I can taste. And again, it's that bringing them back into the body instead of the mind. It's regulating, because we're getting out of those angry thoughts and kind of back into the present moment, the physical space, so to speak. Breathing is a great one. I know we all know it, but really making sure our kids are breathing correctly. So what that looks like is they want to feel their belly contract with the breath in and expand with the breath out. We don't want them breathing through their nose. We want them breathing through their mouth. If they're breathing in their chest, they're hyperventilating. And that's only going to spin out that fight or flight even more. So we really want to teach them how to breathe with their belly. Holding the breath can help with that, like this box breathing. And then I know it doesn't sound helpful, but it is distraction techniques. And we're not saying I distract and then I never address the issue. We are distracting to regulate, right? So we're distracting to come down from a 9, get into a 6, because at a 6, even if I'm still upset, I can at least still engage. And when we think about the places we want our kids to be successful, at school, with peers, during hard conversations, we need them to be able to come back down to a space where they can still problem solve. When behavior becomes a crisis, sometimes the best thing we can do within our clinics and sometimes with our families is have a safety plan. What those protocols are really there to do is not to, again, punish our kids or say, well, if you act out, this bad thing's going to happen. It's to set those boundaries and parameters so that when we are in crisis, we don't have to think about it. Because that's always the problem, right? And it's true for our kids too. That's why we want to teach them this coping. When we're in crisis, when we're at that 8, 9, 10, I'm not doing anything helpful. It's hard to engage with that. So a crisis plan similar to this, right? What are the behaviors that are going to signal like point of no return, unsafe behavior? What are the warning signs for that? Because we want to have coping ahead of time, right? We spell it out. I've made coping cards, I've made bracelets, I've made keychains with kids. Obviously in the office, in a primary care office, we always don't have time for that, but encouraging families to do that, or at least writing their coping on a card, to have them be able to have it ready to go. Because again, when they're usually angry, they can't think. But a safety plan like this can help with that as well. Or you as a clinic can kind of define within your care team, not for a specific kid, but just in general. What are our steps? What are our warning signs? What are we going to offer kids? Kind of works on both levels. Resources to consider that we can always recommend, right? We have so much time within a clinical interaction to provide skills, but we can always offer additional coping things for families outside, right? So knowing that there are several different types of apps, the Calm app has a lot of meditation skills on it. Happify is one. I Breathe. There's a CBT one that's free that can help with anxiety and those good CBT skills. All of these are kind of meant to, again, be that tool so I don't have to think about it. And then obviously knowing that we have internal resources as well, right? So T-Chat really serving as that referral space for that holdover care. How do I get 5 really good sessions of something to almost take that step up from what you have the time to do? You can give that little nugget of education, but then they can get a little bit more support and implementation before they can find longer term care if they still need it. Or knowing that CPN is available for that consultation piece if you feel like medications or referrals are needed. Okay, so now we can talk more about PCPs and medical providers. What is within my capacity, right? Sometimes that's just gain as much information as you can to help recommend, right? We can do as much education as possible, but knowing that, again, we don't always have unlimited time. So the more information you have, the better you can guide recommendation to what kinds of treatments or what kinds of intervention can help. I think helping parents learn to track behaviors sometimes gives the best understanding of etiology, right? Because there's a very big difference between something that is like burgeoning psychosis versus I've just learned that if I cry enough, I can have ice cream every night. Or if I get angry enough. So helping them track and understand those patterns can also help you and the family understand what recommendations are needed. Providing those resources, reminding them of what's available in the community, but also through their schools can be really helpful. And then providing some of those brief educational items that we talked about, right? Understanding how to track the ABCs, helping them develop emotion regulation tools, and then helping coach on some of that brief coping can be a big part. So let's revisit Jack. As we remember, Jack is a 10-year-old male in 5th grade. He's presented to established care because they just moved in from out of state a couple months ago. And yes, sorry, I'm looking at some of the comments. I love the 5 sentences technique. That's a favorite of mine. Yes, that understanding sometimes is the biggest part for families. Going from my kid gets angry for no reason to there are reasons why my kid gets angry. Is a huge stress unburdening for families a lot of time. And again, it's helping understand that it's not our kids being bad, it's our kids getting needs met in unhelpful ways. Changes our compassion a lot, and especially our kids who are chronically angry. Our families can feel very burnt out. And so helping that mental shift sometimes is a huge part of dysregulating the whole environment. Yeah, so back to Jack, keeping that in mind. They've moved in. Again, he's having some issues at school right now, it sounds like. He lashes out when he has to transition, when he has to do work independently, and when he has to stay in his seat. And he's been aggressive with some peers. So based on, again, our brief time together, what are some strategies that you may ask his mom about? Or just, we can even start with, what would you want to know more about?
And if you'd like to unmute yourself, you're welcome to do that. This is a great time to just engage and learn from each other.
Absolutely. Yeah. Okay. So what we want to know more about triggers and antecedents. Absolutely. We want to understand a lot better on, okay, what about transitioning tasks, or what about his peers is kind of setting him off. I think also, again, very short vignette, but something we're missing is report from home. So is it going on at home? Is it not? Because that could be huge. Yeah, history of trauma, absolutely. We have no idea how some of these things may be connecting to really hard past experiences. Exactly, yeah. Defining if energetic is at home or school only. Mhm. Sorry, did someone unmute? Yeah, and getting better definitions of what some of these behaviors look like. How was he at a previous school? 100%. That definitely speaks to, is it maybe like an ADHD and there's underlying stuff there, or is this purely the new environment? Yeah, when did the change help occur? How is he feeling about the move? Absolutely. Great stuff.
I was going to say, can you hear me?
Yes.
Having been in the school system teaching 3-year-olds, they several of the behaviors that were exhibited after meeting with the parents, you could see where the problem was or is. And
absolutely.
Unfortunately, parents want to throw a blind eye to what actually is taking place.
Yeah.
And unfortunately, the child is the one who ended up suffering.
Mm-hmm.
So that's what I think is so important for us to get a handle on in the schools. And the they usually say the apple doesn't fall far from the tree, but you could be highly educated, doing well professionally, and your child is exhibiting these behaviors, but you're in denial about it.
Absolutely.
So I just wanted to integrate that comment.
Absolutely. No, thank you so much for sharing that. I think that is so true. And I think when we are thinking about in the office and, wherever that looks like, how do we get families on board with this idea? It can be usually pretty easy to say, oh, yeah, your kid's got all this stuff going on. It can be a lot harder to get people on board with the idea that the environment is playing a part. And oftentimes with our kids, the environment is playing a big part. And the younger they are, the more the environment is playing a part. Caregivers are involved in that environment, how they're responding to their own stressors, how they're coping. Again, what they're modeling has a huge part in that. And that can be a really hard conversation because a lot of the defensiveness, for lack of a nicer word, of, well, I don't need to be told how to parent. I know what I'm doing. I'm not, no, this is my kid, can come up. And so I think that exact point is sometimes the dance we have around getting families on board with understanding where this is coming from, is helping them understand y'all are doing the best with what you got. And we know that, again, behaviors have a function, and we have to help you and your kid understand what those possible functions are and what some of those things are. So thank you very much.
Dr. Schneider, something I thought of, I was one of those kids that moved a lot as a child. And I think about something that maybe we wouldn't normally think. He may have been like the leader of the pack at his last school, but now he's the bottom of the totem pole. And so now he's trying to figure out where he fits in this new play group per se.
100%. You're also kind of hitting on his own developmental space of 10, is still a child, but we're preteening it. I think, especially in, not to sound like a back in my day, but in our more modern society, kids are getting, maturing younger in some ways. The example I'm thinking of is I have an 8-year-old friend that I hang out with, and they were told by a peer that they were being a baby because they were wearing a character shirt, and they were 8 in first or second grade. So that point that you're making, Laura, of peer status starts to become important in that middle childhood, but could definitely be important for Jack at the age he's at. It's a great point. talking through the ABCs. Exactly. Yeah. Being able to, again, understand. And especially at Jack's age, we can involve him too. We don't have to talk about him. Our kids are really able to engage with these conversations when they feel like we're coming from a place of wanting to hear them instead of wanting to talk about everything they did wrong. And so that attitude can help with this as well of, Jack, you got into a fight on the playground. That sounds like a really hard situation. What was going through your head? Like, tell me a little bit about what led up to that, and not just getting caregiver report in that moment. Yeah, lots of good stuff about how caregivers may be modeling or their own history, asking about bullying, asking about previous testing and diagnoses, 100%. So then what are some strategies or recommendations you would want to make for Jack and his mom? Either if you feel like it's something you could tackle in office, or just the types of care team individuals you'd want to involve, or the referrals you'd want to make. Yeah. So making sure parents are kind of understanding that idea that anger is a need, is communicating a need, and aggression is getting that need met in an unhelpful way. Yeah. So helping them understand it, especially if they think it's purposeful, or, oh, he's just being mean to be mean. Yeah. Screening, 100%. Wanting to understand if there's some other diagnostic items rolling around in there. Because again, kind of like we were talking about, anger secondary to sensory overstimulation for a kiddo with a neurodevelopmental disorder versus anger as a coping reaction for anxiety. Two different ballgames. We're going to handle those differently. And so even that information can help inform the referral source, like maybe myself, or if you have access to a behavioral health consultant, that information helps inform them of where care should go. Yeah, advocate for environmental changes. A big thing that I introduce with families early on is special playtime. So having a dedicated 5 to 10 minutes where that kid is getting one-on-one flooding of, I love you, you're wonderful, you're important, you're in control, you value. It kind of helps fill their bucket a lot if the anger is connection seeking. And compliance-friendly environments. How much can we just make an environment fit the kid instead of forcing a kid to fit the environment? Because again, I think because of, I don't know, maybe age, maybe because kids are kids. We try to squeeze them into a setting instead of helping that setting fit them. So yeah, environmental changes for sure. Give them guidance and resources. Yeah, guidance is great. Starting, again, maybe it's just starting with that ABC chart so you can understand the function a little bit better, and then tailoring referrals and recommendations based on that. 100%. Yes. Yeah. Our kiddos who have that demand avoidance, again, that can't versus won't can be so important about creating that compliance-friendly environment too. And again, that's that things that my kid won't do versus things my kid can't do. Awesome. Okay. Well, if we had all the time in the world, I think an ABC chart to explore the function of aggression, 100%. Maybe we could teach in office a little bit of that emotional awareness, right? Have him and mom figure out how he wants to show how his anger escalates. And then maybe throw in some of those really easy, quick regulation skills. But if that feels beyond the time that you have, the information that you have, or you just feel like kid really needs a little bit of extra support, always referring for those additional services. And utilizing CPAN and services like that. This is just a fun additional information of some things we can give caregivers, just some extra information. Lots of good books on here, some websites that have good information, and some ways to help support caregivers and knowing that they're not alone when they're handling kiddos like this or having one of their kids have a hard time. But I believe that is it for me. Yeah, any questions or additional thoughts that I can answer?
Such an excellent presentation, Dr. Schneider. This is a rinse and repeat because she does such a great job on this topic. And this is a topic that primary care providers just run across all the time. And parents sometimes are just at their wits' end, and to be able to have some nuggets like you gave us, Dr. Schneider, is really, I think, is really critical. So would love to open up the floor for our primary care providers to ask questions. I mean, you have an expert here. And we would love to be able to support you however we can. That's an interesting comment, Dr. Marin. Did you, Dr. Schneider, it says here, I just read an article that said Gen Z teens have as much anxiety as adults without the coping mechanisms. We deal with this even with our own children. So that's interesting.
Yes, I total transparency. I haven't dug into it all that much, but I have been, I know it's kind of a hot topic right now of this anxious generation and how that's being manifested with the accessibility of information and with social media use and with the way that we're being charged with interacting nowadays. I admit don't know a whole ton about it, but I think it is very interesting. And again, some of that history that we want to think about when we're helping kids understand how they're reacting and why they're reacting.
I want to remind those that are on the call today, if you are a Texas primary care provider, family medicine, pediatrics, even OB-GYN, if you are working with patients age 0 through 22 and they have mental health needs, you can reach out to CPAN in your region. I see a number of our providers from our Northeast Texas region here, but I also see folks from outside of our region. Please know that CPAN is here for you to help support your practice. And I'm going to place the QR code in the chat here. Thank you for reminding me.
Dr. Snyder, do you have any parenting classes for them to attend?
Great question. So at this time, we don't have any parenting groups running. That is a goal that we've had for a while. And so hopefully that is something we'll be able to implement pretty soon. I will say, Laura, am I allowed to talk about additional like grant funding initiatives that are coming up?
Oh, go for it. Absolutely.
Okay. So I actually did, we have some new grant funding that will hopefully be, the aim is to help increase the step care model that we have available here in East Texas to address these behaviors before we need to refer to outpatient psychotherapy. And so part of that will be arming providers with information to kind of do what we were talking about today of how do I intervene in the office. And then hopefully also offering a additional parent management training option. So the answer is not right now, but soon, hopefully.
Yes, I will share the slide deck with you. If you're interested, please email me and I will put my email address in the chat right now. And if you are a primary care provider in Texas and you are not enrolled in CPAN, please reach out to us. Even if you're not in our region, you can email me and I'll get you to the region that supports you. This is available for providers across the state of Texas, all 254 counties. And so our job is to support you because you are the boots on the ground helping these kiddos. And so we know that your time is limited and we know that their mental health is of utmost importance. So let us be there for you.
I'll answer this last question really quickly. It was when you're dealing with complex situations like multiple presentations, multiple contributing factors, what strategies do you use to untangle? Unfortunately, unfortunately, I don't think I have anything special or additional other than good information and tracking it, right? And I think sometimes that's the hardest part because our kids don't always come in regularly. But if we do have a kiddo that we're seeing on a little bit more of a regular basis, or if we're able to get them in for those 3-month follow-ups for various reasons, and I think that can help track it. On again, we want the immediate what's going on, but we also want that better understanding of the history, right? And it doesn't mean we'll be able to understand it for every situation, but the cool thing about generalization is that if we can be close enough to the main issue or activating event, it will trickle down and help some of those other more complex pieces.
All right. I think we're at the top of the hour. Our next session is actually going to be facilitated by Dr. Jamin Blood, one of our child psychiatrists here at Texas CPAN in Northeast Texas. It's Does This Kid Really Have Bipolar Disorder? And I think that this is a new session. We've not done this before, and Dr. Blood just finished up the slides for this one. This was actually a request from one of our providers here in Northeast Texas. So we're excited to be able to present that to you on April 22nd. At noon. If you are not on my distribution list and you would like to be on our distribution list, please send an email to that cpaninfo@uttyler.edu and we will send that off. We have a few more sessions coming up through the summer, and then starting this fall, Baylor College of Medicine will be facilitating CPAN sessions across the state of Texas. Each of our hubs will be doing a session. And we're excited to be doing this at a statewide level. So, Dr. Schneider, you're amazing, as always. We appreciate you and your expertise today. We thank you all for joining us today, and we hope to see you on April 22nd. Have a great day, everyone. Bye now.
Thanks, Laura, and thanks, everybody. Feel free to email if there's anything I can do.